Assalamu alaikum and good morning to everyone. Myself Dr. Shahzad Anwar, I will be your host for the day. To begin, I would like to invite the person due to whose constant effort this program has become a reality, and under his guidance Department of TB and Respiratory Diseases has reached a new height. He is really an inspiring figure to us all. Please welcome Professor Mohammad Shamim, Course Coordinator and Chairperson Department of TB and Respiratory Diseases, to tell us about the program in brief.
Assalamu alaikum and good morning to all of you. First of all, I would like to welcome our Pro Vice Chancellor, Professor Mohammad Hanif Bey, Principal and Dean, Professor C. Sharma, Senior Faculty members, and our international faculty, Dr. Jamalul Azzi, who just reached from Malaysia at 2 a.m. in the morning, and he's here on time. Dr. Pratibha Singhal from Mumbai, was ex-Secretary Indian Institute of Bronchology, and Dr. Naved from Kashmir, Dr. Khurshid, and Dr. Rahul from Jammu. We have a faculty right from Kashmir to Kanyakumari. So I welcome all of you into this GYAN program. Basically, this GYAN program was a flagship program of Ministry of HRD. GYAN stands for Global Initiative of Academic Networks. In this, the Government of India funds the international faculty, TA, the honorarium, all. It covers the TA traveling allowances and honorarium to the foreign faculty. The rest, the national faculty, we have to generate from our own resources. So in the next 5 days, we will have a galaxy of faculties from all over the India, and some will be joining right now. I welcome, and now we will start our first session. Thank you.
Thank you, sir. And now we will start our first session. For that, I would like to invite the chairpersons of the session, Professor Mohammad Hanif Beg from Department of Cardiothoracic Surgery, GNMC, and Professor Kamlesh Chandra from Department of ENT, GNMC.
First session of this advanced course in pulmonology under the aegis of GYAN. And we have in this session 4 speakers. Dr. Khurshid Dar, he will be speaking on anatomy of larynx, tracheobronchial tree, and mediastinum, anatomy for rigid bronchoscope. So I request him to please start. And the time allotted to him is 30 minutes.
Dr. Khurshid.
Good morning, everyone. Respected teachers, it's always nice to be to a place where you spend the best time of your life. And the answer, I would like to thank Professor Shamim and the whole team for giving us the opportunity to speak at such an event. So I will be discussing the applied anatomy of tracheobronchial tree. What is important for us? Us means the interventional pulmonologist. So today's talk will be covered three headings. The first is the endobronchial anatomy, and second will be the relationship of the larger airways to the surrounding vascular structures, and third will be the relationship of intrathoracic lymph nodes. A brief introduction why we need to know the anatomy is because if we know the firm understanding of the normal anatomy and its relationship to adjacent structures, it allows us to avoid complications during procedures and achieve optimal results. And second important thing is nowadays it's the time of MDT meetings. So when we meet with our colleagues from oncology, radiation oncology and the medical oncology, so we can give them an exact know-how where the lesion is and which part is affecting and what is possible and how we can properly stage the lesion. From our old days, we know that airways are divided into two, the upper airway anatomy, upper airways and the lower airways. The upper airways are nasal cavity up to the larynx and trachea downwards to the bronchi or lower airways. The first thing is the nasal cavity. When we do a fiber optic bronchoscopy, we go through the nasal route. The first structure we see is the inferior turbinate on the lateral side and the septum on the medial side. The second important structure that we should know when we go down is the vallicula. It is basically the space between the base of the tongue and the anterior surface of the epiglottis. This is the site where foreign bodies lodge in children. Third important structure when we go down is the epiglottis. It is a prominent curved flap in the anterior and the superior position. But one thing should be, we should remember that this structure that as is shown in the picture is basically when we stand behind the head of the patient. If we go from facing the head of the patient, then this will get reversed. Larynx is another important structure. When we go down by doing bronchoscopy, we have to look at these structures. We have to look at the epiglottis base, then we go to the two arioepiglottic folds, then the cartilage posteriorly, and the important thing is the pyriform sinus, because we have to look at the pyriform sinus. It is important because there are something which most of the time we miss the fullness of the fossa or any hidden malignancy there, and the vocal cord movementus or any vocal nodule or any vocal cord pathology there. A little bit down we can see when we are in the larynx is that we can see the anterior rings of the trachea, and we anesthetize the patient properly so that there is no laryngospasm there. Right down we go, there is the trachea. Trachea extends from the inferior margin of the cricoid cartilage down to the carina. The average length is around 11.8 centimeter. It is mentioned differently in literatures, varies from 10 to 12 centimeter. It's formed of 18 to 24 incomplete rings anteriorly. Posteriorly, it is membranous, formed by the trachealis muscle. 1/3 of the trachea lies above the suprasternal notch, that is the extrathoracic trachea, and the rest 2/3 rise into the thorax. Now the diameters of the trachea, the colonal and the sagittal diameters. The colonal diameter is around 13 to 25 mm in males and 10 to 20 mm in females. The sagittal diameter is again 13 to 27 in men and 10 to 23 in women. The diameters, why these diameters and the length are important is because when we are planning a rigid bronchoscopy, we should know the diameters and the size so that we can properly choose our cope, which cope we have to use. And in stunting the tracheal lesions, these dimensions are important. The carina is the first branching of trachea. It's related to the manubrium sternal junction anteriorly and the fifth or sixth thoracic vertebra posteriorly. The mean subcarinal angle is usually around 56 to 61 degrees. The left mainstem bronchus branches at a more obtuse angle. In the pediatric population up to the age of 15 years, there is no statistical difference in the right and the left mainstem bronchial angles. Right down there, there is a carina. There are two pictures. The one on the right is taken when we face the patient, and the second on the left is the left one is when we are standing behind the patient. The right mainstem bronchus is around 2 cm long with a diameter of 1.5 cm, and it leaves the trachea at an angle of 25 degrees. Then we have the right upper lobe bronchus. It's the first lateral branching down at the end of the right mainstem bronchus. It's a short tube. It divides into three. The 12 o'clock is the superior segment. At the 3 o'clock and inferior is the posterior segment, and anterior is the anterior segment, and we can it RB1, RB2 and RB3 respectively. Then we have the bronchus intermedius. Is the continuation of the right mainstem bronchus. It runs for around 2 cm and divides into medial and the lateral segment. It divides into the right middle lobe and the right lower lobe. Then we have the right middle lobe. It's again around 1 to 2 cm in length, divides into medial and lateral segment. The medial is the B5 and the lateral is the B4 segment. Then we have the right lower lobe. It has 5 segments on the right side. The superior segment takes off just opposite to the origin of the right middle lobe bronchus, and we called it RB6. Then going down on the medial side is the RB7, the medialis basal segment, and then going down we have the 3 segments in the direction of anterior, lateral and the posterior. The left main bronchus, it diverges at an angle of 45 degrees from the midline. It's longer, it's 4.4 to 5 centimeter long. It helps and is more narrower than the right one. These dimensions helps us in differentiating between right and the left. Distally, there is the left mainstem carina, where the left main bronchus divides into the left upper lobe and the left lower lobe. Then the left upper lobe, it again divides into left upper lobe proper and the lingular segment. The left upper lobe has 2 segments. There's the apicoposterior segment, the B1 and B2, and an anterior segment, B3. Whereas the lingular segment has the superior and the inferior segment, that is B4 and B5. Then the left lower lobe bronchus is very short. It divides into apical segment. Just bronchus of the left lower lobe is B6 and the basal. There is no basal 3 segment. There is anterior, lateral, posterior. There is usually no medial basal segment on the left, but it's not a rule. Sometimes it can have the same orientation, same number of segments as that on the right side. Now a word about mediastinum. We know there is superior, anterior, middle and the posterior mediastinum, and these are the contents of these various compartments. But what is important for us is to know this thing. When we enter as a bronchoscopist, what is the importance of mediastinal anatomy is nowadays we are doing the transbronchial needle aspiration. It's an old one now. Now we are doing EBUS. So we should exactly know the scanning pointers where we scan for the various lymph nodes, and we should know what is the relationship of these vessels to these main bronchi. Now first of all, esophagus. Esophagus in its length it lies in the posterior mediastinum with the descending thoracic aorta posterior to its left. On the right side it is covered by mediastinal pleura. Esophagus is important for us because all the mediastinal lymph nodes cannot be assessed through the mediastinoscopy or through the endobronchial ultrasound. Now there is a technique, we call it endo ultrasound, done by gastroenterologists. They go through the esophagus and search for these lymph nodes which can be sampled. One more approach is that is done by us as pulmonologists. We put the same endobronchial ultrasound probe into the esophagus to get sample some of the lymph nodes which cannot be sampled through the EBUS scope. The right mainstem bronchus is related anteriorly to the superior vena cava and posteriorly to the azygous vein. The importance of this is, you will come to know during this talk, the azygous vein is important because it helps us in dividing the N1 nodes from the N2 nodes. That in turn helps us in staging the tumor properly. Now the trachea, when it divides into the principal bronchi, it takes place behind the ascending aorta, to the right and below the arch of aorta, approximately at the level of sternal angle. These vascular relations are important because when we do an procedure endobronchially, we have to identify them and also to prevent the complications. The two structures that are related to the anterior wall of the right main bronchus in the upper part of the ascending aorta. The upper part of the ascending aorta lies anterior-medially and the superior vena cava is placed anterior-laterally. The right pulmonary artery lies in close relationship with the intermediate bronchus. It is on the anterior side. Now again the arch of aorta is close to the upper part, now the left mainstem bronchus. The arch of aorta is close to the upper part of the left main bronchus and the left pulmonary artery ascends over its anterior surface. Now the thing that is more important to us and that is more interesting to us as the pulmonologists is to know exactly the various lymph nodes, where they are placed and how we can sample them. This chart, this is everywhere available. These are the various groups, that is the superior mediastinal nodes which are 1 to 4, then we have the aortic nodes 5 to 6, then the inferior mediastinal nodes 7 to 9, and then the N1 nodes 10 downwards up to 14. The first is the supraclavicular nodes, the level 1 nodes. They are the low cervical, supraclavicular and the stelloid nodes. They are from the lower margin of the cricoid cartilage, the claviculus and the upper border of the manubrium. The midline, the important thing is in group 1, the midline is the midline of the trachea. Whatever is right to the midline is R1 and whatever is left is L1. This diagram, but down the station 1, from downwards, the left border is the lateral border of the trachea. It is not the midline. It is the left border of the trachea. That is important. Any node up to the left border of the trachea, left lateral border of the trachea is right, and beyond that is left. Now the upper paratracheal, that is the 2R nodes. They extend from the left lateral border of the trachea up to the left lateral border of the trachea and from upper border of the manubrium to the intersection of the left brachiocephalic vein. The 2L nodes, they are upper border of the manubrium to the superior border of the aortic arch. And these nodes are located to the left of the lateral border of the trachea. These are the 3 nodes, level 3, there is 3A and 3P. These are the prevascular and the prevertebral nodes. The prevertebral is behind the esophagus. Again, the importance esophagus comes into place, and the 3A is, these are nodes in station 2, but they are anterior to the vessel. The lower paratracheal, these are the nodes. They extend from the lower margin of the left brachiocephalic vein up to the lower margin of the azygous vein and up to the left lateral border of the trachea. The 4L nodes, the lower paratracheal, they are from the upper margin of the aortic arch to the upper rim of the left pulmonary artery. This is a CT description of the 4R and the 4L. Now one thing important here is the 4R node is, it is not a single node. It can have 3 locations. While performing an endobronchial ultrasound, if the node is anteriorly, the vessel behind it will be the aorta. If it is little bit anterior-laterally, the vessel behind it will be the SVC. And if it is laterally, when you are doing an EBUS, the vessel will be azygous vein. Azygous vein importance, again, anything below azygous vein is station 10. Anything above azygous vein on the right is station 4. These are the subaortic and the para-aortic nodes, which are lateral to the ligamentum arteriosum. These nodes we cannot access through the EBUS. We do access these nodes through the extended mediastinoscopy or through the EUS. Although station 5 have been, there are some case reports that station 5 can be accessed through the EBUS but going through the pulmonary artery. This is again a CT presentation of the 5 and 6 nodes. Now, subcarinal nodes on the right, they extend caudally to the lower border of the bronchus intermedius, and on the left to the upper border of the left lower lobe bronchus. This is space here, it's a 5 centimeter is the width, and the distal end of the subcarinal space is formed by the left atrium. So when you are doing an endobronchial ultrasound for a subcarinal node, the vascular structure, the Doppler signal that you see distal to the C7 is the left atrium. The paraesophageal and pulmonary ligament nodes, these are the N1 nodes which are down caudally up to the diaphragm.
3 minutes over.
The station 10 is the hilar nodes. These are nodes adjacent to the main stem bronchi and hilar vastus. On the right, they extend from the lower border of the azygous vein up to the interlobular lesion, and on the left, from the upper rim of the pulmonary artery up to the interlobular lesion. These are the 10 on. This is a CT presentation of the 10R and 10L nodes, and these are the interlobular nodes that are present lower down between the division of the right upper lobe bronchus and the right middle lobe bronchus, that is 11 superior and 11 inferior. Now, why these lymph node structures are important is because all this comes into place is where we stage a tumor. For example, in this cartoon, we have a tumor on the left lower lobe. So, for the left sided lesion, any N1 node, that is 10, 11 and up to down, these are all N1 nodes. The same side, the 4L, 2L, 7, 8 and 9. If some of these nodes are involved, then they become an N2 node for a left side tumor. And anything on the opposite or the station 1 node, they become an N3 node. So this cartoon shows us that station 1, 2, 4, 7, they can be sampled by both through EBUS as well as mediastinoscopy. The 10, 11, 12, these are in addition to upper, these nodes that I mentioned can be sampled through the EBUS scope. And 5, 8 and 9, they can be sampled through EUS scope, through the esophagus. All these are exclusively done. However, station 4, station 2L can be sampled through EUS, as well as station 4R can also be sampled through EUS when it is large and bulky. A word about blood supply. The trachea is supplied by the tracheal arteries, which are the branches of inferior thyroid artery.
You have 2 minutes only.
Okay. And the tracheobronchial tree is supplied by the bronchial arteries, which are the branches of descending aorta. The venous drainage from the lung is again into the azygous system and the accessory exogynes. A word about rigid bronchoscope. There was mentioned its anatomy of the rigid bronchoscope. Rigid bronchoscope is basically a set of hollow tubes of varying size that we use when doing intervention procedures, and it has a universal base with multiple ports for various accessories to be used. This is the optic that we use in rigid bronchoscope, and this is the stent loading and deploying system. Thank you.
Since these topics are interrelated to each other, we will have a discussion after the fourth speaker. So, second speaker.
Thank you.
Now, I invite Dr. Pratibha Singhal to please come on the dais and give her presentation on how to set up an operating room for interventional bronchoscopy, that is rigid bronchoscopy, and time allotted is 20 minutes.
Thank you, respected chairpersons and dignitaries in the audience. I thank Dr. Shameen for inviting me here. It's my first time at AMU and I'm thrilled to be here. So the topic that has been given to me is quite interesting. It is a setup of the bronchoscopy suite in the operating room for interventional pulmonology. So we are going to the first few slides that are going to be there are going to cover what we are set up as the Indian guidelines for basic bronchoscopy, and then we will move on to what additional equipment we need. This is still under publication and it is with a joint effort by the Indian Association for Bronchology, ICS, and the NCCP. So what is a dedicated bronchoscopy suite is an ideal place to perform bronchoscopy because you're going to follow certain criteria for patient safety, ease of procedure and airborne infection control, and therefore it should be performed in a suite dedicated for this purpose. There are many guidelines which are available for what is a minimum basic requirement. You have the BTS guidelines, you have the European guidelines, you have the ATS guidelines, ACCP guidelines. Well, what we decided is that for the Indian perspective, the minimum requirement should have at least 3 rooms, approximate size being about 250 to 300 square feet. One is a room for pre and post procedure monitoring, one is a main procedure room, and a separate room ideally for bronchoscope disinfection and storage. I know in many institutes this is not ideal, but at least then you should have 2 rooms at least. So the minimum essentials here, one related to the bronchoscope and the associated devices. So the appropriate bronchoscopes depending upon what all procedures are being carried out in that particular institute. So at least an adult video bronchoscope, one pediatric bronchoscope at least should be there for if you're having basic bronchoscopies, and the corresponding equipment needed for biopsies, brushes. For interventions, you must have the CRE balloons and the syringe pump, specimen collection devices, syringes for medication delivery, and other equipments. Oxygen and oxygen delivery equipment, medical vacuum suctions, either the central or the portable suctions, infection control devices, that is the gowns, masks, eye shields, adequate ventilation measures, anesthesia machine, Fowler's bed, post-procedure monitoring bed, and tables and cupboards. For monitoring, resuscitation trolley, defibrillator, continuous NIBP, saturation and heart rate monitoring. And when you're doing intervention procedures, then you must also have an ETCO2 monitor. And you must have a separate decontamination area for disinfection, which also has adequate continuous water supply and a deep-seated sink to rinse the equipment. When you're adding on to your basic bronchoscopy suite, remember you should also have a C-arm enabled OT table with side attachments because you're going to start using the fluoroscope, and you need side attachments when you're doing medical thoracoscopy because you need to turn the patient, elevate the patient's hand. Pediatric bronchoscope in today's day and age is must. Why? Because you also need sometimes thin bronchoscope for going more peripherally. For the endobronchial ultrasound, ideally linear, yes. Radial is not always available in all institutes, but you should have that. More than the original video bronchoscope monitor, at least one additional monitor, preferably 2 monitors, so that your assistant can also see, and you have one monitor distal so that you can have endoscopic image and the endobronchial image side by side, because when you have sometimes picture-in-picture image, the image becomes very small. Flexi-rigid thoracoscope or the pluroscope, cautery machine and the argon plasma coagulation machine for interventional procedures is important. Fluoroscope, rigid bronchoscope set. Dr. Khurshid has already told us that you need some assemblies. We're going to discuss some more in the next few slides. Cryo machine with 2 size probes, 1.9 and 2.4 millimeter. Recording software would be ideal, though it is not mandatory. View box, and as I've already said, central oxygen and central suction and portable suction. Anesthesia is very important. The next talk is going to be covering this, so I'm not going to go into this in much detail. So this is what is the bronchoscopy suite for one of the institutes that I work at. I'm attached to Reliance Hospital and Bombay Hospital. So this is the suite at Reliance Hospital. As you can see, it's quite fancy. The suite at Bombay Hospital still is not so fancy, but you can see that there is, you have the C-arm enabled table. There is a C-arm. This is the main trolley, which has the EBUS equipment also, the processor. There is one screen, there's a second screen, and you have the anesthesia machine. The important thing is for there to be adequate movement space in case there is some emergency and you need to move the patient. So that is why we have said that ideally you should have at least 300 square feet. In the operation theatre, it is important that you have the operator, you have an assistant immediately, then you have a nurse and the trolley with all the equipment and the anesthesia team. Important that when you are doing procedures with difficult airway, jet ventilation backup would also be important. Ideally, it should be performed in a room with negative pressure design, where ventilation of at least 12 to 15 fresh air exchanges using HVAC, mixed or natural ventilation. There should be a direct exhaust to the outside air, and HEPA filters must be used if recirculation of air is unavoidable. Personal protective equipment to be worn by all health personnel in the bronchoscopy suite. This is something important which sometimes I think we forget, especially because we deal with a lot of tuberculosis in our country. If you're suspecting TB, please use the N95 mask. I know sometimes, it is not, N95 masks are not easily available. So if you're suspecting TB, please tell your bronchoscopy staff to make arrangements in advance. The health personnel in close proximity to the patient during bronchoscopy should ideally wear eye shields. This is not only when you are suspecting the patient to be HIV positive or HBsAg positive, but ideally should be for all patients. Because sometimes when the patient coughs, there could be spillage of secretions into the surrounding air. Needles ideally should not be used to remove biopsy specimens from forceps because this can cause inadvertent injury to the operator. And all staff should ideally be vaccinated against hepatitis B and should receive annual influenza vaccination, which again sometimes we forget to do. But this is important not just for us but for all the bronchoscopy staff. So staff concerned with cleaning and disinfection of bronchoscope should wear adequate personal protective equipment, and ideally you should have latex or nitrile powder-free gloves. Hand hygiene should always be performed immediately before and after removing the personal protective equipment. So I'm sorry if you can't see too well, but ideally this is what would be recommended for an interventional bronchoscopy procedure room. So you have a common area, then you have the accessory stations, which are the workstations, and you have supply storage. But this is the basic minimum that you should have. You have a waiting area for family, a reception, pre-op recovery area, procedural suite, and a separate area for processing the equipment. Now this kind of a setup would be the most ideal, is what you see internationally in many bronchoscopy and interventional procedure room. They usually share the space with the endoscopy people, so it's almost sometimes easier to have that. Unlike where in our institute sometimes we have separate bronchoscopy areas and endoscopy areas, so it becomes much smaller. So why rigid? Let's come to what is the main center point of today's CME is the rigid bronchoscopy. So there are certain advantages. I'm sure there will be some overlap in the subsequent talks as well, but please pardon me for that. So because there is better control of the airway, ability to ventilate while performing a procedure, important to manage bleeding, easier to remove debris, larger biopsy pieces, coring, which you cannot do with a flexible scope. And importantly, the flexible scope can be introduced through the rigid scope, using the rigid scope as a intubation conduit. Indications I think are going to be covered by Dr. Aziz, so I'm going to skip this. For therapeutic procedures, however, please remember a bronchoscopy department must have a rigid bronchoscope. Important to also know when to be careful, what to buy. I think this is important when you're setting up a rigid bronchoscopy suite. You have bare essentials where you have these barrels of various sizes. Okay. Initially, I know in the earlier era, everybody did not have a telescope. So when you don't have a telescope, you can attach the prism and the light source, and then you can operate with the eyepiece of the scope, which is on this side. However, now I think this is also the bare essentials that you have. You have this eyepiece head, then you have this rubber pot to fit on the head of the barrel so that the instrumentation can be done. This is for the suction, This is the prism, and this is the rigid and the flexible suction catheters. Now this is what would be ideal, where you have a telescope, a 0 degree and a 30 degree telescope, a 0 degree at least basic minimum if you cannot get 2 telescopes, and some biopsy forceps. This is just to have some basic idea about when you're doing a pediatric bronchoscopy, rigid bronchoscopy. There is a formula where you can calculate what size of scope to use. Other instruments which you should have are your crocodile forceps, then you could have serrated forceps with a tooth, then you can have a peanut forceps which are slightly rounded, as you can see over here, so that it can accommodate a bulky foreign body. Multiple teeth forceps to grasp flat bodies, and you have other types of forceps. Now this is what you would want if you're going to do stenting. So if you're going to start doing stenting, then you must have your stent loaders. Okay. The scope that is being shown here is the two commonly used scopes are the Karl Storz and the Dumont scopes. So this is what is the set for the Dumont scope. It is color coded, and the stent loaders are also color coded, so it is easy for you not to go wrong. As Dr. Khurshid has already mentioned, doing a bronchoscopy to know what size of rigid scope you may need to use for a patient eventually when you're doing intervention procedures is important. Then these are some other advanced instruments. This is a cautery. This is a rigid domia. Cost. Again, I think this is where a lot of us start wondering what we are doing and how much we need to invest. So approximately 10 lakhs with basic set and accessories. Each additional tube barrel can cost about 40,000. Telescope is for 2 lakhs. Formalin chamber for 7,000 for disinfection, which is important. And CRA balloons are usually 20,000 to 30,000. What is a team that you need when you're setting up bronchoscopy? So it's not like I say, okay, today, oh yes, I want to start doing rigid bronchoscopy or have an interventional suite. It's not possible for me to do it alone. You will need 1 or 2 assistants and 1 good trained technician. Anesthesia backup cannot be emphasized upon how important it is. Post-procedure ICU care for therapeutic procedures, and if you're doing procedures like coring, or if you now cryobiopsy where it rarely could be bleeding, sometimes it is important, especially initially in your initial few procedures, to always tell your surgeon friend. It is important when you're doing intervention procedures to have a CVTS surgeon as a friend. Please do not make the CVTS surgeon your enemy. So how do we do it? Pre-op evaluation, anesthesia, ventilation, insertion techniques. Pre-op preparation includes cardiopulmonary assessment. Important to have the anesthetist see your patient before. Detailed evaluation of the medical condition, including evaluation of the oral cavity, teeth, neck mobility and jaw. Important to see the mouth opening, okay, because sometimes we don't realize that and we don't know whether it's going to be a difficult intubation with a rigid scope. If you're planning procedures with interventions, multidisciplinary team sometimes is important, so you need to speak to your anesthetist and to your cardiac surgeon, CVTS surgeon, to say that please, I may need you, so please be around. And of course, you need to have a flexible bronchoscope because sometimes you may need to pass that through the rigid scope. And always, before you start your procedure, check your instruments, because you don't want that you have induced the patient and then your instrumentation is not working or you don't have the right equipment. Anesthesia, good understanding between the anesthetist and bronchoscopist. For short procedures, topical lidocaine with IV sedation. Longer procedures, you'll need complete paralysis. However, important thing to remember here is that you avoid muscular paralysis initially in those who have upper airway narrowing, because the airway could suddenly collapse. Okay, so I'm not going to go much into this. So rigid bronchoscopic intubation, I'm just going to cover a few slides on this. Several methods that are used. You have a classic method, or you have intubation using a laryngoscope, intubation along with an endotracheal tube, or insertion through your tracheostoma. So the classical method is where the insertion of a rigid open tube bronchoscope is done. This is important to first train with, because this may not be as easy as it looks. The safest method is insertion under direct visual control through the illuminated telescope. which should not be overextended beyond the end of the rigid scope. Otherwise, you will not really be able to see where you are. So the patient is in supine position with the head in hyperextension. Important to remember to protect the teeth by the thumb and the index finger, because you don't want injury to the teeth or the lips. The teeth must never be used as a fulcrum. I think initially when you see your initial PGs, they're trying to lever the scope, rigid scope, using the teeth, and they land up damaging the teeth. The key landmarks are the your uvula and the arytenoids. So once you identify the vocal cords, then you turn the bevel tip to push the vocal cords on one side and enter the trachea. Some just few pointers. Important thing to remember is that people land up overextending the head. Please don't do that. Important is that the tragus and the vocal cord should be on the single flat line for it to be easy insertion. Important to remember instrument safety. Hopkins telescope is a more sensitive part, and therefore it should not avoid when you're even loading the instrument, to avoid touching it on hard surfaces and damaging it. Always have hot water to avoid fogging and damage, and keep a detachable rubber tip of suction catheter, because that will prevent distal damage to your instrumentation. How to begin? So when you begin rigid bronchoscopy, choose your patient carefully.
Dr. Singh, 2 minutes more.
Yes, sir. Last few slides. Unstable cardiac status and refractory hypoxemia patients should not be the ones that you take initially as your first few procedures. If there is a unstable cervical spine or severe spondylosis, please don't do the procedure. Inadequate jaw opening, do not do the procedure. Most important for any kind of procedure, which holds true for bronchoscopy and rigid bronchoscopy too, is an inexperienced bronchoscopist or not having good anesthesia backup is the most important and absolute contraindication to performing any procedure. Know your limitations and keep an informed consent ready. So rigid bronchoscopy is safe, not difficult to learn, extremely rewarding, and complements the flexible bronchoscope. It is essential for interventional procedures, and a good rapport with teamwork and anesthetists is important. There are no specific guidelines mentioning how much training you need, but there is some data which says about 20 supervised rigid bronchoscopies, and then doing at least 10 per year is what could be a good number to be well trained in rigid bronchoscopy. Thank you.
Thank you, Dr. Pratibha Singh, for a very good presentation of rigid bronchoscopy. Now, I call upon.
So, due to some urgent work, Professor Kamlesh Chandra, one of our chairperson, has to leave. So, before leaving, I would like to say that, sir, please come forward on stage and felicitate Dr. Khushid Dar and Dr. Pratibha. Dr. Khushid Dar, kindly come on stage. Professor Kamlesh, you have to also felicitate Dr. Singhal. Now I would invite Professor Rakesh Bhargav from Department of TB and Respiratory Diseases to felicitate Professor Kamlesh Chandra before he goes. Now I would invite Professor S.C. Sharma, Dean, Principal and CMS, to kindly come on stage and felicitate other chairperson, Professor Mohammad Hanif Beg, sir. Thank you, sir.
We are a little behind our schedule, so certainly we have to carry on with the third presentation. And this presentation will be done by Professor Moeed Ahmed, the chairperson of the Department of Physiology of our medical college. He will be speaking on anesthesia for rigid bronchoscopy, and time given to him is 15 minutes because we are behind schedule. I know that you can manage.
This is very unfair, sir, but anyway, I've got to honor his request. At the outset, I must congratulate Shamim for doing such an excellent academic feast, and respected chairpersons, thank you so much for your, your dictation, what you said. Okay,
But, you can have a liberty to have a little more time.
all right, sir. I'll just tell you what I needed. So, most of my talk has been already dealt by my previous speaker. She has done good, wonderful job making my things bit easy, and of course, I can come to your, can respect to your demands, sir. So, nothing to disclose, and the learning objectives are, what are the primary issues during rigid bronchoscopy? What are the primary concerns during anesthesia? What are the different ventilation strategies which we have during fiber optic rigid bronchoscopy? And what specific precautions during post-operative period? What are the troubleshoot? What are the pros and cons of this technique, and the key points to remember at the end of this presentation? I'd ask my residents, who was the person who's known as the father of bronchoscope, rigid bronchoscope? Anyone from the audience? I have a chocolate for you. No one? No, it's not Jackson. It is Gustav Killian. He was the person who did the first esophagoscopy and removed removed a bone from the pig. So naturally, he is the father of, known as the father of, rigid bronchoscope way back in 1898. And then subsequently, Algernon Coleridge, who did the first successful removal of tracheal foreign body in 1898, and later on Jackson, what you said, devised a lighted bronchoscope. That was indications I've already dealt, and my subsequent speaker will be dealing. I'll not go through that. Contraindications, again, he will be speaking on that. But remember, there is no absolute contraindications. There are very few, but relative contraindications are coagulopathy, extreme ventilation and oxygen demands, and tracheal obstruction. There are very few contraindications because it's an emergency. We need to do it, means we need to do it. Now, what are the issues during rigid bronchoscope? As my previous speakers have already highlighted, now these are the patients who are really critically ill. They are ASA 3 and 4 as per American Society of Anesthesiologists, which means their respiratory reserve is very limited. Hemodynamically, they are not stable as such. So that is again a very difficult to deal with people. Both the anesthesiologists and the surgeons are dealing the same area and the same position. Naturally, you've got to leave the surgeons or leave the pulmonologists the area. So any critical situations, one has to be cooperating with each other to give the situation to the other people. So handing over takes some time, dealing again, managing your equipments at the same space, giving same area to both the people. So we are dividing that area becomes a very critical issue at times. Position of the patient has been said, hyperextension. So naturally, when we think about it, we always have to keep in mind what are the restrictions, limitations of our cervical spine, whether we're going to go for a cause more trauma to it. So in situations where the patient has restricted neck movement, again, doing this type of technique becomes, there are limitations on this. The device itself rigid means you cannot mold it, you cannot manipulate much. So you have got to be restricted to the dimension and to the structure of the device, which again has some limitations whenever we talk about molding or deviating from the original side. The technique of anesthesia, it's an open airway. Remember one thing, it's an open airway means that means you will not be able to at times maintain the level of anesthesia. So we've got to take care of it. So monitoring while under anesthesia, at times there are certain techniques which are apneic ventilation, where we are not being able to monitor the carbon dioxide level, so the patient is oxygenated but not being ventilated, which means the CO2 goes on rising. Keeping the time frame is again a very important for us, and then monitoring carbon dioxide becomes very difficult. So complete reversal of anesthesia, because at times we will be giving some mass relaxants. So reversal of these patients can be a difficult situation, especially when patients are already critically ill. And so we got to see that the patients are having a proper post-operative care. Right? How to avoid these morbidities? Naturally, very important, you've got to go have a very good coordination between the operator and the anesthesiologist. One has to know the limitations and one has to give the priority of one person to the other. So we've got to preempt things. If you are having any situations, we've got to know that these are the situations we've got to keep in mind. And as my previous speaker said, keeping all the devices which are needed to manage that, tackle that critical situation should be there in the operation theatre. So it should be performed in an operating theatre. This is very important. And radioscope. So they have to be a radioscope which can visualize any critical situations which is there inside the lungs immediately, and you can manage it. So they need to be there, and availability of the vascular embolization and extracorporeal circulation. That is one. ECMO should be there, extracorporeal membrane oxygenation should be there, because at times maintaining oxygenation of these patients become very difficult whenever you have a dislodgement of stent or a growth or a tumor blocking the whole component of the trachea. Got to keep this in mind, and availability is very important. Crash card means we have a difficult airway, you've got to keep all the modalities with you, especially the Manujet or the jet ventilation, along with the CPR. The trolley should be there with you. Now, pre-anesthetic assessment is very important, because you need to preempt things. You've got to keep in mind what are the situations the patient might be having intraoperatively and how are you going to deal them. So rigid bronchoscopy is done under general anesthesia, keep in this mind. So naturally we've got to keep all the things ready. And we are tackling with ASIG 3 and 4 patients. So they are not hemodynamically stable, they are not, respiratory parameters are not good. So we got to see that all the pre-operative investigations are there at hand. And we need to identify the patients, whether the patients are having proper coagulation profile. The pulmonary function test, especially the spirometry, which tells you whether the patient is having inspiratory stide or an expiratory stide, or whether the blockage, the obstruction is extrathoracic, intrathoracic, so that we can manage accordingly. We have to keep this. So those investigations and those examinations are very critical for before we go venture into any sort of anesthetic technique. And CT scan to locate any growth or any existing stent which is being dislodged has to be done. MRI at times becomes very important, because to find out the dimension of your trachea, dimension of your bronchus, where exactly the location of your growth is, or where the stent you're going to put a stent or obstruction is. So they are all at times very important. And precordial and preoperative ABG to know the baseline hypercarbia and hypoxia of these patients. They are supposed to be there with you. So the clinical examination, particularly attention should be there, as my previous speaker said, what extension and flexion the patient has as far as the jaw is concerned, where the mouth opening is adequate. Restricted mouth opening could be there, head neck extension flexion might be difficult. Requirement of extra oxygenation means preoperative SpO2 or oxygen level of this patient should always be kept in mind. And the increased risk of intra and post-operative procedural complications, they are all something which we have to keep in mind. What are the anesthetic considerations? Now let's talk about this. Ideal anesthesia requires, one is balanced anesthesia. By saying balanced anesthesia, what we mean is the patient should be hypnotic, they should be analgesic, and they should be muscle relaxant. Now these muscle relaxants are not always been given. There are certain ventilation strategies where we don't give muscle relaxants. We can do away with muscle relaxants. We'll come to that later on. Avoid pressure response. Now this is very important because you are putting a tube, putting a rigid bronchoscope, so there could be a lot of pressure response over the larynx and the trachea, which can shoot your blood pressure, cause a lot of cough and cough problems, and laryngospasm. So naturally pressure response is very important in these situations. Maintenance can be done with propofol, remifentanil, and inhalation. All these things can be used. Remifentanil is it's a bit recent drug. Most of the institutions might not be having it, but it's a wonder drug. We can go ahead with it. Nitrous oxide is very important. It is contraindicated because there could be always a chance of obstruction, which can cause overinflation of your alveoli, causing pneumothorax. So better is you always try to avoid nitrous oxide in these patients. And short-acting muscle laxants can be given, like succinylcholine, and target control infusion anesthesia analgesia is one thing which is very recently coming up, and they are very good in these situations, especially when you would like to keep the patient in spontaneous ventilation. So where you don't need to give any muscle relaxants, you can go ahead with it so as to know that level of the anesthetic agents, intravenous anesthetic agents, so as to go for a depth of anesthesia. That is, so prevent awareness is again an important, and that is why we have BIS, bispectral index, so that we can monitor what is the level of anesthesia during your operative procedure. Now deep sedation and spontaneous are other options. As I already said, hypoventilation and laryngospasm could be a possibility during this patient, especially when you're putting an apneic oxygenation. I'll come to that later on. The strategies which cause this. Cuffed endotracheal tube and supraglottic airway devices are other options. When you put when we put a rigid bronchoscope, simultaneously we can put an endotracheal tube also. We'll come to that when we do the ventilation strategies. Pre-medication, of course, as I said, the standard pre-medication nil orally, of course, other than emergency situations, H2 blockers, proton pump inhibitors, you go for antisylagogues, and anxiolytics, analgesics, and bronchodilators, they don't have much role in it. Positioning, as my previous speaker said, positioning is always very important because rigid bronchoscope requires hyperextension, but not too much of extension, which can cause problem to the cervical spine, and especially it is very important to see that the patient does not have any spine fracture while you are hyperextending the patient. This is one thing which you can just see. Usually you put a roll under the shoulder, and you can put a donut over the head just to see. Now this is a device which has recently come. It's there in our institution, CMAC, which makes things very simple, especially while you are putting a rigid bronchoscope, and naturally this is the figure which you love to see. And when you negotiate your tube, it becomes very easy for you. Ventilation strategies, the various methods: apneic ventilation, oxygenation, spontaneous assisted ventilation, controlled ventilation, and I'll go one by one: monojet ventilation and high frequency jet ventilation. This is apneic oxygenation. Now, apneic oxygenation is something which we used to do in the older days, but nowadays it's not that much that much not in use. But one thing which has come is the Thrive, that is transnasal humidification of insufflation and ventilation exchange, ventilator exchange. Now that is something which is now coming in, where we go with a high flow of oxygen, about 70 liters per minute, and so we ventilate. We go through the nasal prong. We give oxygenation, and simultaneously we can go ahead with your rigid bronchoscopy. So as to increase the apnea time. Now what we do here is we ventilate the patient with our bag mask ventilation, and then we lift the patient to the operator. Now this is something which is very important. The patient is apneic, right? We give short-acting muscle relaxants, and we ventilate the patient and give it to the surgeon or pulmonologist, and he does his job. So many times I've been assisted our Ani Beg Saab sir, Professor Beg Saab. So we've done this, but this is again a very critical situation. We leave the patient to the surgeon, and we are not being able to ventilate. Then the apnea time goes on increasing, and the CO2 goes on rising. So this is again which is not being done in nowadays. but we can go ahead with it in certain situations where we think that the patient will not, we cannot do other than this. But Thrive is something which is coming in, the future role, we got to see, venture into it, there are a lot of studies which are coming out. Spontaneous assisted ventilation, this is one thing which I was talking about. We can put the patient on total intravenous anesthesia, especially target control infusion with remifentanil, with thiopentone, with propofol, and then we can simultaneously go for an assisted ventilation if needed. So, but the problem is these patients, one is that you are not being able to exactly relax, you are not being able to relax this patient, one. So the patient coughs on the rigid bronchoscope and the patient can land up to laryngospasm. The two very important thing is this. And if you don't have a target control analgesia, a target control infusion, then always a possibility is that the patient can become aware and conscious. So that is why you've got to see that you have a TCI, target control infusion system, where you know what is the level of depth of anesthesia in these patients. So this is again which is there in some institutions. We go ahead with it when we don't have the adequate facilities with us. So this is what we are trying to do. We are primarily hyperventilating the patient, and then we put a rigid bronchoscope, and simultaneously we see if the patient is needing, then we can go with a we can ventilate these patients if the patient goes to hypoxia. And at times when the patient lands up to laryngospasm, we must see that we have adequate facility, especially with the rigid bronchoscope. The moment you remove it, you must see that the patient does not land up to laryngospasm. And we see that the patient's vocal cords are, especially when you are giving propofol, they usually are wide apart, but at times they can close and the patient can respond to your rigid bronchoscope. So this is what we attach the Bain circuit or the ventilated circuit, and then if needed, in between the operating procedure, we can at times assist the patients with their spontaneous ventilation. So we are not primarily paralyzing these patients. Okay, the controlled ventilation is the most widely used system, because we are putting on the rigid bronchoscope. We are paralyzing the patient with muscle relaxants, and we are inducing and paralyzing it, and then we are being able to ventilate these patients. Now there are two techniques which we can do. One is we give the operator the rigid laryngoscope, and with the side port we can ventilate this patient. This is one way. The other way is we can put an endotracheal tube, right? We can put an endotracheal tube, a small size endotracheal tube first, and then we put the rigid bronchoscope. Now this is one thing which we can do so that we can ventilate the patient simultaneously when the surgeons are operating. Now this is what I tried to show here. You see I am putting the endotracheal tube first, and then at the side of this endotracheal tube I am putting a rigid bronchoscope, and you will be able to, but the most important thing is after that you should see with the help of your fiber optic bronchoscope that your endotracheal tube is beyond the level of the tip of a rigid bronchoscope. Now that is something which is not always possible, because it depends that where your rigid bronchoscope needs to go. But at the same time you have to be very cautious that it is not going to block your ventilation. So naturally when you do it, we put a rigid bronchoscope beside the, you can see here we are putting a rigid bronchoscope beside the endotracheal tube, and then we visualize it. I'll just have a short clipping here. And you see that, so naturally we would like to see through the fiber optic bronchoscope that whether my tube is beyond the level of your endotracheal rigid bronchoscope. That is, yeah, this is there you can see the tip of the endotracheal tube. So that is what is, and this is what I said, we attach it to the side port of your rigid bronchoscope and ventilate these patients. Now jet ventilation. Now there are two types of jet ventilation. Primarily one is the manujet, or one is the high frequency jet ventilation, and the other is the manual jet ventilation. Now they primarily work on the Bernoulli's principle, Venturi effect, which entraps air and ventilates this patient. I'll just show you how it is. Now advantage of jet ventilation is that the airway is left open. Actually airway is open and provide a conduit for the variety of tools to complete the needed intervention while maintaining adequate gas exchange. and it also applies high pressure gas flow through the open airway. So that is again because of the Venturi effect, the patient's airway is open and there is an entrapment of the gases. Now manual jet ventilation is a technique which is being described by Sanders way back in 1967, but we have the recent which is being supplied by the the VBM company, which we have a jet ventilation where we have put a narrow size tube and we attach it. I'll just show you how we do it. And then most importantly, the pressure which you have to keep is around 50 psig, and the rate has to be narrowed down to 10 to 14 so that the gas which is being passed inside should get an adequate time to be expelled out, otherwise there will be overinflation of the alveoli. This is what is the jet ventilation which we have. We preset the monitor at around 50 psig, and then we have a trigger which is triggering it so as the pressure which is being released at around 50 centimeter of water, and then we can ventilate with this device, putting the needle, putting the catheter at the side of the rigid bronchoscope, and you can see here that the patient can adequately be ventilated with this. Now this is something which is required both at situations where you are not being able to intubate this patient, you can put a cryo and then ventilate this patient and means oxygenate this patient, or at the same time you can also go for a jet ventilation in this patient. Now this is what the Sanders technique is, a Sanders device, which obviously we have it in our hospital as well. I'll just the other thing which we can have is you have a long catheter which can go to the tip of the rigid bronchoscope, and you can ventilate through that also. Instead of putting a small catheter, you can go till the tip of your rigid bronchoscope and you can ventilate with that. That's the other device which is there. But the only thing is, you've got to keep in mind that the plateau pressure, the peak inspiratory pressure should not be more than 35, and the rate of ventilation should not be more than 10 to 14. Automated jet ventilators, there are dedicated ventilators, which is Accutronic, they supply this Monsoon 3, which has there is combination of high frequency and low frequency jet ventilation, and the other thing is you can also ventilate with one single technique, which is around high frequency. It can range from 60 to 300. Some equipments they have 120 to 600 and rate per minute, and when you have a low frequency jet ventilation, around 10 to 30 per minute. And the advantage is it has a peak, it develops a peak, positive and expiratory pressure, which opens the alveoli, and then oxygenation is improved. So this is one thing which is advantages with high frequency jet ventilation or the low frequency one, that the oxygenation is better when we go ahead with this device. But you should always have a device to measure the PEEP, because it should not be high PEEP where there will be a lot of cardiac embarrassment along with the overinflation, hyperdynamic expansion of your alveoli. So these things has to be kept in mind, and the patient can land up to barotrauma, causing a lot of pneumothorax. So this is the device which I was talking about. If you see this, this is the this is the device which is the dedicated jet ventilator which they have, and that is Accutronic, where you can have with a high frequency jet ventilation. Right. Now this is something which is very new, because what I said is things have become very simple for you, for us as well as for the surgeons. They can use this device and they can easily intubate or put a rigid bronchoscope without much of hyperextension. Now we don't need hyperextension because we have a video laryngoscope where with the help of it we can visualize things and we can make things very simple. So that is what is very new in the rigid bronchoscopy or anesthesia. Intraoperative monitoring, standard, all the things has to be there, ECG, SpO2, blood pressure, non-invasive, invasive, whatever is there. But only thing is that carbon dioxide monitoring becomes very difficult, which is an open airway. So CO2 could be monitored by transcutaneous method or ABG, whatever is needed. And second thing is depth of anesthesia, because it's an open airway, there's a lot of inhalational agents which is coming out. So at times we pack it, we go for a packing of the airway so that the ventilation becomes adequate and there's no leakage of gases which decrease the depth of anesthesia and the patient becomes awake. So naturally that depth of anesthesia has to be monitored time and again so as to see that how much amount of anesthesia you need to give. Post-operative care, obviously recovery is intubation or extubation of these patients is as important as intubation, or putting a rigid bronchoscope and recovery is both are equal for us. And 5 to 10% of these patients may require some emergency intervention, because as I said, the stent may be get dislodged, your tumor can get dislodged, it can cause a lot of bleeding, cause obstruction. So emergency is very, you've got to preempt this. Muscle relaxation is one thing which is very important, because you are given muscle relaxation, so the patient should be properly reversed from the muscle relaxations. And for nowadays we have a wonder drug with us, which is Sugammadex. Whatever drug you give, muscle relaxants, it will immediately reverse the patient. You don't need to wait for 50 minutes, 30 minutes, 20 minutes, whatever it is. Now this drug is a very expensive drug, we don't have it here, but in abroad people are using it. Back mask ventilation with 100% oxygen. Once you remove your rigid bronchoscopy, you need to see, you must go for a back mask ventilation to these patients. And very important, when you are removing your bronchoscope, you must see till the end of your bronchoscope that when you are removing it, because there could be a lot of bleeding, there could be a lot of foreign body which can obstruct your airway. So, and there could be a lot of trauma as well. If the patient is apneic and blood situations are there, you got to remove it and re-intubate the patient, and got to remove these patients, remove the airway. The monitoring, as I said, is very important. Presence of airway crash cart, because as you know, the patient at times who has a very limited mouth opening and got to do for a crash jet ventilation, so you got to go for all the equipments ready. Your supraglottic airway devices, that is LMA, should be there at times, because they are very handy. Dexamethasone has some role in children. Children do not respond, but obviously these patients, they can, preoperatively you can go with dexamethasone to the adult patients as well. The analgesia component, which is very important in these patients, they are primarily because of your laryngeal handling. Laryngeal handling causes a lot of edema and trauma and pain. So that component, with fentanyl or whatever drug you have, you can go ahead with it. Nebulization and bronchodilators for post-operative stridor could be of help to you. Troubleshoot. Now this is something, presence of anterior mediastinal, at times when you make the patient supine, or you given some amount of an inhalation agents or intravenously, this patient can collapse immediately, because if there is a mediastinal growth which can block your trachea, and the patient can collapse. Now that is something which is very risky, and you got to preempt this. That is why pre-anesthetic checkup is very important. MRI, CT scan are very important, and you got to keep all your devices ready. With the rigid bronchoscope at times really helps in these situations. And the other thing is, when you are putting a rigid bronchoscope, you are putting it on one side, the other side does not get ventilated. You must see that both the sides are getting ventilated, and if it is not, then you got to put any extra device there so that you can ventilate that device. Otherwise the patient will go to hypoxia. And at times ECMO, as I said, extracorporeal membrane oxygenation could be needed in situation where you are not being able to adequately ventilate these patients with hypoxia. So you've got to keep all these things in mind, and acute occlusion of airway should always be identified with whatever facilities are there inside the operation theatre, and you've got to manage accordingly. So these are things which are troubleshooting, and you've got to take care of it. So what are the pros and cons? When patency of the airway is compromised by granulation tissue or tumor, rigid bronchoscopy is the only device instrument that can be inserted past the obstruction. This is very important. Fiber optic, you will not be able to negotiate it, but rigid, you can go ahead with it. And it is done in supine. This is one thing. Cons, of course, lot, because done in operating, need an operating room, requires ventilation, teeth may be damaged, as I said, limitations of visualization of your structures could be a problem too. So the key messages are, rigid bronchoscopy requires a team effort. You cannot do it independently. You got to go coordinate with your operator, and it's a safe but a successful procedure. Pre-anesthetic assessment, always, around 50%. NAP4, National Audit Project 4, has shown that if you have not done pre-anesthetic checkup, actually what you're causing is 10 to 15% of your airway problem is because you're not doing a pre-anesthetic checkup. That's what the NAP4 project has shown. So naturally, pre-anesthetic checkup and preempt what problems could be expected should always be at hand, and you should keep these things in mind. Various methods of ventilation are there, as I said. You got to keep those in mind. Whatever is feasible, whatever is suitable for a particular operating procedure, you have got to implement them. And the other thing is, controlled ventilation, of course, as I said, is the choice in the present era. Most post-operative period, Again, word of caution, got to keep in mind that anything can happen during this period. 5 to 10% of the people can require an emergency situation going for an immediate intubation and go for an operative procedure. So it is mandatory that bronchoscopy should be performed in centers with people who have adequate expertise. This is very important. So expert means got to get yourself trained, then only you can go ahead with it. Thank you so much. How much was the time, sir?
Thank you, Professor Mohit. You have taken 35 minutes.
Is it?
Okay.
No, I don't think. Otherwise, you could have given me a warning.
No, I wanted to bell in between, but I thought it is interesting. Why not to listen you all? And
Thank you for that favor, sir.
and certainly the questions. Any question from the house
Yeah,
will
yeah,
be
sure.
dealt later after the last presentation.
One question.
Thank you.
Yeah. Oh, sorry.
Eh,
Can I take my?
Thank you, Professor Mohit.
Thank you, sir.
Now the last lecture of the session, but most important, to be held by the Dr. Jamalul Azizi. He is from the Malaysia, and he just came in the morning here to give this lecture. The topic is basically indication and complication of rigid bronchoscopy. The time is roughly for 20 minutes for you, sir.
And a very good morning. I would like to thank Prof. Shamin, my good friend, and his department for inviting me to this very prestigious event. It's good to see old friends. I see Dr. Nafis Khan is here, who was with me before, and Prof. Shamin himself many years ago, and Dr. Harry as well, and Dr. Pratibha here. So actually my talk has been made a lot easier now after the previous two talks given by Dr. Moide and Dr. Pratibha. So I will go through some of the things quite fast. Whatever that has been covered by the previous two speakers. So rigid bronchoscopy and indication and complications. Just to let you know that my practice, my rigid bronchoscopy practice is heavily influenced by my training in Marseille and by Dr. Dumont as well, legendary Dr. Dumont. So since the introduction of flexible bronchoscope by Ikeda, there was a decline in rigid bronchoscopy. In the past, including myself, the junior fellows and the doctors had limited or no experience with the rigid bronchoscope. But interventional techniques, including laser, electrocautery, stenting, etc., has led to a renaissance of rigid bronchoscope. And rigid bronchoscope is preferred in the situation where perfect airway control is important, often when massive bleeding is a potential threat. And usually both rigid and flexible scopes are used in combination. And rigid bronchoscope is the preferred instrument for many interventional procedures. The working channel, the working field is large enough for you to insert multiple instruments. Like this case I did. You can insert a flexible scope for viewing, and then the suction catheter, what else? The suction, and then balloon bronchoplasty as well here through the side port there. So obviously this is an advantage, particularly when the airways are flooded with blood, secretion of pus. Can we go on? Can we continue? Can you hear me? And then therefore we should have access to rigid bronchoscope to handle this. And rigid bronchoscope is also used to perform mechanical debulking and airway dilatation, pre and post debulking, and to insert stent as well. So the method of insertion of rigid bronchoscope, again, I use the classic technique, already covered by Dr. Prativa. Just to show you quickly what we do, we have the telescope here. Sometimes I use this solution of the pop here to feed the tip of the telescope for intubation. And this again, you heard this before. Just to highlight the things here, the upper teeth are protected by the inlet area or the scar. So here, you can see that. My finger hand, I'm using my thumb here to protect the upper teeth there. And again, the first landmark is the uvula, and then you get advanced bronchoscope using the tongue as acting as a fulcrum, and then the next landmark is the epiglottis. It's very easy to read this, but in real life, actually, it is not as easy as it appears here. Okay, and then to go on, and then until you find Eric knot and the vocal cords. And then then you turn the rigid bronchoscope 90 degrees clockwise, and you use the bellow tip to gently push the vocal cord to one side, right, to the trachea, and then you can turn the rigid scope anti-clockwise. And let's see video of rigid intubation. This is real case. So you can see there the already region and the office there. And sometimes you are faced with situations in real life. So it's not as easy as it appears when you read. So sometimes I use such a catheter and then push the port to one side to enter. Okay. So to perform, you heard it before, complex procedures, diagnostic or therapeutic, you must have rigid bronchoscope. And you have seen this, I think, usually you have tracheal and bronchial tubes, and then from Dr. Dumont, you have the scope head, and the barrel of increasing diameter to do your work. The telescope can be attached to a camera to allow projecting image on the video screen, and then that will allow everybody in the operating room to see what's happening. Okay? And it is also useful when you are teaching your fellows. So rigid bronchoscopy, at this stage we all know that it needs general anesthesia and therefore must be performed in a surgical setting with a nearby recovery room and ICU. And so that's why you must be friends with your anesthetist and your surgeons. And ancillary equipment, suction catheter is very important in rigid bronchoscopy. It can be used to palpate lesion, remove debris. So this is a suction catheter, one of the cases that I did. Okay, and it can be used to perform tracheobronchial toileting, inject adrenaline, etc., etc. Forceps, different type of forceps available. You have foreign body forceps and forceps for stent placement. Scissors, you have scissors. I have used scissors before, but I have yet to use the scalpel. Actually, I don't have a scalpel, so I don't know how Dr. Dumont used his scalpel in his practice. What about indication for rigid bronchoscopy? It can be either diagnostic or therapeutic. So rigid bronchoscopy is not just for therapeutic procedure. So no, I use rigid bronchoscopy to take deep biopsy. Sometimes we are scared to take large biopsy during flexible bronchoscopy because we are worried about bleeding. So with rigid bronchoscopy, you don't have to worry about bleeding, and because normally my practice nowadays, I insert endobronchial blocker whenever I take deep biopsy via rigid bronchoscope. And IBAS TBNA, that is my routine practice in my center, simply because I want to protect my IBAS scope. There's no way for the patient to bite my IBAS scope, and then it is also easy for me to teach my fellows. Okay. Pediatric bronchoscopy, I have no comment about that because I'm not a pediatrician. Therapeutic indication for therapeutic bronchoscopy, lots of them. You're already familiar with this: massive hemoptysis, tumor ablation, foreign body removal, laser therapy, etc., etc. And this is the benefit of rigid bronchoscopy. You can take large biopsy size and absence of coughing and unwanted motion, and you can do multiple intervention. Okay. Oh, sorry. Okay. Limitations. Obviously, not every center has to perform rigid bronchoscopy, and then access. Rigid bronchoscopy is only limited to the more central airway, but that is not an issue because we always use flexible bronchoscopy. We insert the flexible bronchoscope through the rigid bronchoscope to examine the distal airways. So this is not an issue here. Okay, so I'm just going to show a few cases which I had done over the last 10 years or so. The diagnostic indication for rigid bronchoscopy, basically, as I said, taking deep biopsy and to control post-biopsy bleeding. This is my practice nowadays. When I do endobronchial cryobiopsy, I'll insert an endobronchial blocker straight away. So after taking the biopsy, we inflate the balloon and tamponade the area there. So it gives you time to control bleeding and to separate the specimen from the tip of the cryoprobe. Sorry, and the other diagnostic indication is transbronchial cryobiopsy. I think we are going to hear about this topic during this course. And therapeutic, okay, I think a lot of people are interested in therapeutic bronchoscopy. So one of the cases I did many years ago, a patient with right lung collapse due to an endobronchial tumor. So we did debulking, coring technique, and lung expander. Okay. And not only for malignant diseases, you can use rigid bronchoscopy for benign condition like this. A patient, this could be, if you see this patient, this chest X-ray, you might think this patient had TB, okay, but actually it's due to benign endobronchial lesion in the right upper lobe there. It turned out to be hematoma. Actually. Okay, let's see airway dilatation using the rigid tube. In the case of tracheal stenosis, one of the cases that I did. So this is quite scary to do this, and because you're not careful, you might end up with perforation. So this has to be done gently. Okay. And one of the cases that I did many years ago, post-intubation tracheal stenosis, and then we dilated the airway, and then we applied mitomycin C. So that's 6 months, I think, after the procedure, actually, so the airway remained patent. And then we can use rigid bronchoscope to put a stent. In this case, we put a silicone white stent for a case of tracheal tear, secondary to double lumen tube intubation. I have no comment. This was the case was referred to me by the cardiothoracic anesthetist. The patient developed tear, so we put a silicone white stent there, and the patient recovered after that. Okay, so that's. And then for malignant central airway obstruction,
is one of the cases that I did. We did the bulking first, and then using cryo. So that's a cryo probe there. And then followed by laser. And then we did a bit of dilatation before we put a metallic stent. Okay, so that's the metallic stent. Alright, and then foreign body removal, just a quick video. Just ignore the music. Okay, so 2 coins, basically 2 coins were removed from this patient, a psychiatric patient. Okay, so those were the coins. Okay, what about laser bronchoscopy? So in my center we do laser, so it's very useful. Laser is useful for lesion in the trachea and in the main bronchi, in the central airway, and so basically the laser fiber, the suction catheter, and the telescope are positioned in the barrel of the rigid bronchoscope. So this is how we do laser bronchoscopy. And complication already covered by the previous speaker. These are the mechanical complication. It could lead to death as well, and then systemic complications, well known to our anesthetists. There's something I want to share with you regarding the rigid intubation technique. Although it is very, frequently described that you must hyperextend the neck. Okay, but I don't do that routinely nowadays, unless it is absolutely necessary. So most of the cases we manage to intubate without hyperextending the neck. When I do have difficulty to intubate, only then will I extend the neck. So I don't hyperextend the neck routinely unless it is necessary. Okay, conclusion, my last slide. So rigid bronchoscopy is preferred by many in the field of interventional bronchoscopy for safety reasons, patient and pulmonologist comfort. So for us, interventional pulmonologists, we just want to focus on the work, on the case, because we are doing a complex case. We take 1 or 2 hours, so we don't have the time to focus on the anesthesia part. So we have to leave it to the good hands of our anesthetists, okay, to take care of the general anesthesia. Speed of action and saving of time and number of procedures. The wide channel of the rigid scope allows better control of hemorrhage using more effective suction catheters, and the wall of the barrel to tamponade. It also permits deeper biopsy specimen and more efficient debridement. Insertion of prosthesis, retrieval of foreign bodies, and dilatation can be performed while adequately ventilating the patient. So at this time, rigid bronchoscopy is not a dying art. Okay, with that, I conclude my talk. Thank you very much for listening.
Thank you, Dr. Jamalul. If you have any question, we can take 1 or 2 questions. Because next is tea break, you can discuss it in the tea area.
All the lectures which have been presented, they are highly informative. And my comment on these is that the rigid bronchoscopy needs a skill. Its learning curve is more than any other procedures like fiber optic, esophagoscopy, bronchoscopy. And secondly, there must be a good coordination between anesthesiologist and the bronchoscopist. Bronchoscopist can be either from the chest department or from cardiothoracic surgery or coronary. But at the same time, if it is not being done in the theater of the operation theater of cardiothoracic surgery, he or she must be informed properly that, because once complication occurs, this is a life-threatening complication. So therefore, you must have a good coordination between all three teams: anesthesia, bronchoscopies, and cardiothoracic surgery. With this, I once again congratulate all the speakers who have presented their work so well, so informative. Thank you very much, and I give the mic to the organizers.
So thank you, sir. I would like our chairperson of the session to kindly felicitate Dr. Jamalul Azizi. So Dr. Jamalul Azizi, kindly come on the stage. Next to be felicitated is Dr. Syed Moeed Ahmed. Sir, kindly come on stage. Thank you, sir. With this, we have come to the end of our first session. Now we will break for 15 minutes. The next session shall start from 10:45 a.m. Thank you. So we are in short time we are going to start our second session. So everybody is requested to kindly come inside the auditorium. So welcome back. To begin our next session, I would like to call upon the chairpersons of the session, Professor Farzana Beg from Department of Pediatrics, JNMC, Dr. Saurabh Kumar Singh, and Dr. Parminder. Dr. Saurabh. So I request our chairpersons to kindly invite our first speaker of the session.
Assalamu alaikum. Let's begin our second session, and the first speaker for this is Dr. Pratibha Singhal. It's a privilege to introduce her. She is Secretary to Interventional Pulmonology Group, European Respiratory Society, and from 2018 till 2021. She is an Associate Editor for IIB Journal, Thoracic Endoscopy, past Honorary Secretary of the Indian Association for Bronchology, awarded Fellowship for Training in Pulmonology, EBUS, Sleep Medicine and Pleuroscopy at Cleveland Clinic, Ohio, and NUH Singapore. Faculty at various national conferences and workshops, a well-known faculty, and she is also faculty at CMAS for bronchoscopy courses. I welcome Dr. Pratibha to deliver her lecture on management of foreign body.
Thank you, madam. Thank you, chairpersons, for that warm introduction. I thank Dr. Shameen again for inviting me here. So the topic that we are going to discuss now is management of airway foreign body. So let's look at some introduction of what happens with foreign body aspiration. It's usually in extremes of age, and only 20% of cases occur over the age of 15 years, most common in children. It is a potentially life-threatening condition because it can worsen at any point even if the person is clinically stable, especially again in children. Traditionally, historically, rigid bronchoscopy was a cornerstone of treatment for foreign body removal. However, the evolution of flexible scopes has expanded the role of pulmonary physicians in the diagnosis and the management of patients with foreign body aspiration, and gradually pulmonologists are taking over the role of the ENT. So some things to consider is what predisposes patients to foreign body aspiration in adults. In children, it is very common because they have a habit of putting things in their mouth. But in adults, what predisposes them is alcohol intoxication, sedatives, poor dentition. So when you have loose teeth, or you have loose bridges or loose metallic caps, mental retardation, neurological disorders, or other conditions which cause impairment of swallowing and consciousness, like general anesthesia, or secondary to a seizure. So this is a patient who underwent laparoscopic gallbladder surgery 3 weeks prior to presenting to us with cough, and incidentally his x-ray showed a metallic foreign body, and you can see that this is what we had removed, was a whole bridge of this thing which had gotten loose during the intubation and gone in and nobody had realized. Types of foreign body: you have the organic, which are usually the food products. These cause severe inflammation and can swell to more than 2 to 3 times their size and can cause severe obstruction. That is why it is important to know what foreign body you are dealing with, because that will help you in aiding how to figure out and plan its management. Inorganic, which are more common in adults, like teeth, dentures, caps, tablets, pins, and in our country, betel nuts. Clinical presentation: very often in adults, they can be asymptomatic. The triad of choking, cough and breathlessness is usually not seen unless it's a large foreign body, or it is more common in children. Patients may just have some cough which is gradually progressive, may have shortness of breath, can come with a post-obstructive pneumonia because of the foreign body and therefore fever. Hemoptysis if it's sharp. Rarely do they have inspiratory stridor if it's getting blocked in the larger airways, and sometimes chest pain. Clinical diagnosis: often in adults, the diagnosis that patients come and we initially make are pneumonia, chronic cough or unexplained etiology, hemoptysis, or sometimes they come with an obvious foreign body aspiration history. Radiology: X-ray findings can show you a collapse with or without a mediastinal shift. You can have a non-resolving pneumonia, and obstructive emphysema, especially in children with large airway foreign bodies. You can see that there is a shift of the mediastinum and hyperinflation of the contralateral lung, or sometimes you can see a frank metallic foreign body on the X-ray. Flexible bronchoscopy is a gold standard for the diagnosis of an airway foreign body, and now in experienced and safe expert hands, it is safe and an efficient procedure for removal in adults. So before you embark on a flexible foreign body removal, please remember that you need to have a lot of instrumentation in your bronchoscopy suite. So the various instruments that you will need are the Domia basket, you have the fishnet basket, you have the snare, you have the pronged forceps, the flat forceps for flat metallic foreign bodies. Then you can even simple biopsy or punch forceps can grasp metallic foreign bodies with a sharp edge. The cryo is an important tool now for removal of organic foreign bodies, and you have this Fogarty's balloon, which also plays a role, because when you have an impacted foreign body like this and you don't have any space to get your domia or your snare around it, sometimes you can push the Fogarty's beyond it and inflate the balloon and pull it up so that you dislodge the foreign body slightly more proximally for better maneuverability. Anesthesia: if you are doing a fiber optic removal, it can be performed in a local anesthesia. The advantage in this is that sometimes it helps in preserving the cough reflex, and therefore if the foreign body gets stuck above the glottis or it dislodges from the forceps, then you can just turn the patient and ask the patient to cough it out. If needed, endotracheal intubation. However, important to remember that very often the foreign body, if it's large, can get stuck inside the endotracheal tube. Therefore, the LMA is a good alternative when you want to have the patient under general anesthesia. For fiber optic removal, always when you're suspecting a foreign body, please use the oral approach because you don't want to put it through the nose and have the foreign body get stuck in the nasal passages. Balloon, if needed, can be used. Once you see the foreign body, then the instrument that you need for the grasping, once it is in the grasp of the instrument, then the whole assembly, that is the foreign body, the grasping instrument and the scope is removed en masse. Remember, keep the scope and the foreign body in the center to keep it always under vision. Otherwise, sometimes if you do it in a hurry, you will lose the foreign body and then not know where it is gone, and you may actually land up releasing it in the left side when originally it was on the right side. If it is subsegmental, very distal and it is metallic, then sometimes you may need localization with the help of a fluoroscope if you can't see it. So let's look at some cases. This is a patient, middle-aged gentleman who, while undergoing a dental cap fitting, coughed and somehow aspirated his metallic cap. And as you can see on the X-ray, I don't know whether you can see, but there is this slight metallic thing over here, and on the CT you can see it's lodged in the posterior, left posterior basal segment. He's undergone a flexible bronchoscopy outside, which was unsuccessful. Then somebody has done a rigid bronchoscopy where maybe because they used a larger scope, they couldn't even see the foreign body because it was much more distal. And then this patient came to us where we have done a flexible bronchoscopy under GA, and you can see it is lodged in the left posterior basal segment. The advantage here is that because it has a loose, sharp edge, we managed to grasp it with a simple grasping forceps. Important thing to do here is not to tug it quickly because you can see it is slightly impacted over there. If you try and just quickly tug it and get it out, it will lose contact with the forceps. So gently just ease it out and get it proximally. And this is what we managed to get out. This is a patient who was referred for a non-resolving pneumonia. He was intubated for a stroke. You can see that once you go into the right bronchus intermedius, there's a lot of slough. And one would think it is just mucus plugging, but once we cleared it out, you saw that there is this piece of coconut sitting there. He probably aspirated it at some point before he had the stroke, and this was easily removed with a Domia basket. This is a patient whose CT showed just this basal nodular shadows. X-ray, you can see that there is this metallic foreign body there. Again, he came to us already with the CT scan. In the presence of metallic foreign bodies, sometimes you don't even need a CT scan. X-ray can be diagnostic enough and you can go in and do a diagnostic bronchoscopy. So there is this metallic screw which is lodged at the opening of the lower basal segments. And what you can see, what we're doing is we're going to open a domia, create a space around it, try not to push it further, and we've tried to catch the distal end into the domia. Once you can feel the grip, you gently close it. If you close it, important to remember is that your assistant here is very important. Sometimes if you have an untrained assistant who gets very excited at seeing that, oh, it's already entrapped, and they close it suddenly, with this thing, foreign body can slip out. So it has to be closed gradually till you get a firm grip and without completely sometimes closing the instrument. This is a patient who was undergoing dental fitting for his dentures, and you can see that there is this metallic foreign body here. This patient had to undergo a bronchoscopy without anesthesia. Sorry, I think that's not playing, but you can see this is what we managed to remove. The important thing here was that because this was the proximal portion, we could just easily grasp it with a grasping forceps and get it out. I'm sorry, some of the videos are not playing for some reason. Okay. Some challenges that you need to remember are in patients who are on ventilator. You can have patients who come with hemoptysis as the initial presentation, or even when you remove and it's a sharp edge, you can land up causing a little bit of bleeding. The management is going to be the same as is going to be covered in the next talk. Sharp foreign bodies, remember you have to prevent them from getting caught in the mucosa. Wedged foreign bodies can be extremely painful. Migratory foreign bodies, this was a paper I published in JOPIB in 2004 where a denture during removal kept moving from the left to the right main bronchus because the patient was coughing. And foreign body aspiration syndrome, very often patients aspirate pills, and when you actually go in you don't really see much except a lot of inflammation and granulation. So this is a patient who was in the ICU, had a non-resolving pneumonia. You can see that there is tracheostomy there, and I think what happened was, unfortunately, there was this radio-opaque foreign body here which was missed by everybody. There's a pneumonia distal to it, and when we went in, it was the molar which had got dislodged during intubation and gone in. As you can see here, it's quite big, so it got stuck in the tracheostomy tube, and we had to make arrangements to quickly remove the tube and again recannulate the patient, insert a new tube. This is what I was telling you about bleeding. This is an impacted metallic stud of a gene which a child was fiddling with, and you can see that it is causing a lot of aberrations here, but again, because it is metallic, it can be easily removed. This is a young girl who aspirated her the pin of her when she was pinning up her burqa and holding it in her mouth and talking at the same time, which is a bad thing to do. Obviously, you can't be holding something in your mouth and talking or laughing. So she's had an aspiration of the pin. Let's hope this plays. Now, sharp foreign bodies are again difficult because not only do they injure the mucosa, but they can also cause trauma while being removed. So here you can see, fortunately the metallic part was proximal, the sharp edge, and it was stuck in the mucosa, and the distal end was free. You can see over here. So what we are doing is we are using a simple grasping forceps, and we are going to slowly ease out the foreign body from the mucosa. Try and grasp it as close to the sharp tip so that you don't cause further damage while removing it. Yeah. So this was a fairly long pin which was removed. Complications that patients can present with. So sometimes the initial presentation itself can be with complications like stenosis, bronchiectasis, hemoptysis, post-obstructive pneumonia and abscess formation and granulation. This was a gentleman who had a recurrent pneumonia for almost 10 years before he presented to us, and when we did a scopy we saw there was a slough in the middle lobe. On removing, there was this granulation, and on cauterizing it there was a piece of supari sitting inside which we removed, and eventually his lungs completely cleared up. This again is a patient who has this what looks seemingly like this area of partial collapse and consolidation. There was a lot of slough here. On clearing it out, we found supari, and important thing always, okay, you can see here that there are multiple pieces of betel nut that were found from the same segment. So always remember not to forget to look for more foreign bodies after you have removed the first. So a careful inspection of the tracheobronchial tree is important. Cryo. This is a new tool for foreign body removal. The advantage is that the probe can be placed in contact with the foreign body, and freezing is performed till the contact point is frozen, and then the whole assembly is removed. It is especially useful in organic foreign bodies and blood clots. So this is an elderly gentleman who had a left main bronchus obstruction on the CT scan, and you can see there is this huge piece of betel nut which has swollen. It's almost looking like a mass when actually it was a betel nut. So these are famously notorious betel nuts actually in our country because they swell up, they are hygroscopic. Okay, and you can see that at this point we did not have a cryo forceps and we are struggling with the domia to get it out, but this would have been a perfect example of a foreign body to be removed by cryo. I brought this especially to show that this would have been quick with the cryo, whereas we struggled hard and we had to then eventually remove it piecemeal, as you can see here. So it has come out piecemeal for us, eventually it did come out, but you can see that it took a lot of time. Okay, so flexible versus rigid. Now this is always the dilemma, and as Dr. Aziz has very importantly highlighted that a lot of us, when we were undergoing training, did not have training for rigid. Okay, I think Hari is one of the lucky ones who's actually gone and trained in rigid, but most of us have learnt either with some form of international short courses or then learnt on the job. So remember when to go in with rigid. Important is in adults, when you have a large foreign body, you have an impacted foreign body, but in children, rigid bronchoscopic removal is probably the first thing that you would undertake, and try not to do a fiber optic removal. Why? Because the forceps are small and these patients have usually ventilatory compromise. So you don't want things to go wrong when you're trying to do a flexible removal of foreign body in children. So important to diagnose, this was a patient who was referred to us with the diagnosis of a pneumonia on ventilator. However, you can see that there is a complete collapse. There is no air bronchogram. There is already a little shift of the mediastinum that is beginning to occur, and we suspected that there was a foreign body. Because the patient was in the ICU, we put in a pediatric scope through the endotracheal tube and first diagnosed that there was a foreign body, and then this patient was taken up in the OT to remove the entire thing. So you can see that with the flexible we managed to just get this little bit out, whereas this entire bit was removed only with the help of the rigid. This is a short video to show you how, when you have large foreign bodies, what is the... So once the patient is under anesthesia and the scope is in place, in this video there is no telescope, so you're seeing it through the direct vision. Put in the grasping forceps. Important thing is to keep, if it's large, don't try and remove it through the channel or the barrel of the rigid scope, and remove the entire thing en masse in the same angle that you have inserted it, the same angle, while keeping the position maintained and not lose the foreign body. So this is what was removed in this patient. It was a large piece of betel nut. These are some other foreign bodies in children which have been removed. This is a whistle from the shoe. You know, you have those squeaky shoes. This is a whistle. I don't know what made the child swallow that. And this is a spring from a cap. Now this one, it was in the left main bronchus, so we managed to do it with a fiber optic. This is a gentleman who is a known COPD and who had this persistent cough and wheezing despite optimal therapy. As you can see that there is not much on the X-ray. He underwent a CT scan and you can see there is this hyperdense lesion within the right main bronchus, and there is some distal collapse. Now this patient, because he was hypoxic on presentation and had been in the ICU, we decided that we will do a rigid bronchoscopy and then pass. Again, we did not have the cryo at this point, and you can see this was completely impacted. No amount of trying with the balloon or with any of the rigid forceps was it coming out. So we actually had to use a cautery. It was again a betel nut which was swollen up. We had to use a cautery to break it and then remove it, and you can see that we have eventually managed to snare it out completely. We managed to finally pull it proximally and snare it out. So some of these videos are just to highlight that sometimes it can be very simple and quick, and sometimes it can be extremely frustrating, but at the end it is the most rewarding thing to remove. So some tips and tricks to remember when you are doing this. Never endoscope a suspected foreign body unless you are prepared. So make sure that you have all the instrumentation, because I don't have unfortunately the video or the images for this, but recently we did a removal in a patient who had undergone 4 bronchoscopies outside, 2 flexible, 2 rigid, and what was in the right main bronchus had eventually been pushed into the right lower lobe posterior basal subsegment, and it was a nightmare for me to remove. We eventually got it out, but it was a nightmare. So something that was simple was unfortunately made complicated by trying multiple times and pushing it further and further. So never endoscope a suspected foreign body unless you're well prepared. Ventilate the normal lung adequately so that the patient is not hypoxic. Look at the lie of the foreign body because that will help you sometimes, and position the scope on the foreign body. Ensure that the patient is relaxed if you're struggling. If you need to, then you convert the patient from awake state into GA. Larger foreign bodies have to be trailed behind the